when you do a T10 to pelvis fusion, I mean, sure, you're improving someone's life and, oftentimes they're falling over, they can hardly stand up, but they're not like gonna go snow skiing afterwards or play basketball. I mean, they're not physically high functioning anymore,
Mhm.
right? I mean, they weren't to begin with, so you're improving them, but they're not getting to that level, right? Whereas I was watching these patients that we were doing with Dr. Landman as a fellow, and then later in practice, and of course they're not always multi-level. They could be 1, 2, 3 level disc replacements, and they're quickly getting back to. I mean, most of them getting back to all their sports and not having any pain. I mean, it's a huge difference. It's a total game changer.
Welcome back to another episode of the Spine Pod. This time we are sitting down with Dr. Jason Cuéllar in Palm Beach Gardens, Florida. And I'm excited about this episode. 1, because apparently we love to go to Florida.
We do.
And 2, you know Dr. Cuéllar personally, and I was so looking forward to meeting him in person, and he did not disappoint.
Absolutely. I think this is such a special one because so many of the surgeons that we sit down with, we get to know so well professionally, right? We follow their surgeries through clinical trials, what they do, who they work with, through the industry partners, right? But I've gotten to know Dr. Cuéllar very well personally, and I think not only getting to tell his journey of medicine, but his journey of his life, right? And how his family has played a role in that, and his wife played a role in that, and his faith journey, and the way that he looks at medicine. I think it's so special, and it's very gratifying and humbling to be able to sit down with him, tell that story, and then be able to share that with our audience.
Absolutely. And he was previously in Beverly Hills with another one of our favorite motion preservation surgeons, Dr. Todd Landman. And he made the move to Florida about 2 years ago. And it is so impressive what he has already built in that short period of time. His practice is booming, and it's mainly with travel patients, which any surgeon out there knows that's a hard thing to accomplish. And he's, that's the majority of his patients. And it speaks to something that we love to talk about, which is if you do motion preservation, the patients will find you, and they are finding Dr. Cuéllar in droves. And it was amazing to see.
Absolutely. I mean, they're opening new clinic locations. They have clinic locations from Jupiter all the way down to Miami because they need to take care of all the patients that they have. And they're building a surgery center too.
So exciting.
Right?
Yeah.
But I think you're so right. I think it speaks on behalf of 2 points that we talk about all the time, right? One, which is that if you're doing motion preservation, patients are going to come. He's not just doing single level cases, right? He's doing 3 level and 4 level and 5 level cervical disc replacements, and he's doing multi-level lumbar disc replacements as well. There's only a handful of surgeons in the US that are doing that. So now he's got patients, he's known for that, and he has patients that are traveling in to come see him and to get that care. And the second part is how big of an influence the training and the mentorship that he has had and the people that he's worked with. I mean, you look at his training from UC Davis to Stanford to NYU to Cedars-Sinai. I mean, he's worked with some of the best of the best in spine, right? You talked about Dr. Todd Landman. Then you look at Hyun Bae and Neil Anand and Peter Pashas. I mean, he has worked with everybody across the spectrum. And I think it's given him such a good perspective on providing better care in spine, which is what we talk about all the time.
Absolutely. And not only that, he was a patient himself. He has a lumbar disc in his back. And I think that provides another level of empathy and ability to provide care because you know what it's like to be on the other side of the table. And you see that through how he thinks about care, how he interacts with patients, how he's built his clinics. And I loved hearing his own personal story because I think that gives a lot of insight into why he practices the way that he does.
Well, he has such a unique perspective as a provider, right? He is a surgeon, but he has also been a patient. So he knows what it's like to give treatment, but also to get treatment, right? And be on the other side of the table. Also, with his PhD background, he's a scientist at heart, right? So he looks at implants and biomechanics as a lot of the surgeons that we talk to do, but he also talks about some of these other ancillary biological processes that are occurring, right? The cytokine response, the inflammatory mediator response that drives these pain generators. It's something that we often don't talk about, right? And so his research, as he talks about cytotonics and A2M and some of this other work that he's doing outside of just hardware and implants, it's what's making spine better, right? And I think it's what makes him such a holistic provider and provides this really high level of care that you just don't get to see everywhere.
I agree. And I love to see how passionate he was about that. Made me really passionate about it. And like, I didn't even know about any of this before we sat down. And now I'm like, I want to go read up on it and understand it more. And just the complexities that still exist just in healthcare and like science in general, but like in spine, like we still have so much to learn, which is really exciting. And sitting down with someone like Dr. Cuéllar gets you, like, allows you to see that there's so much other stuff going on that we don't even really know about that is just going to make care better and better as time goes by. And we're excited that we got to sit down with him and talk about it.
Absolutely. And 21 years of education and training, and he still might not be the most educated person in the household. His wife is also an orthopedic surgeon. You don't get to see that often.
No, so, and both of his kids speak multiple languages.
I know. Like, I know. There's something to learn there, right? There's something to learn. But both him and then, we got to talk about his wife, Dr. Vanessa Cuéllar, who's a hand and wrist surgeon down in the area as well. But just the best at what they do. And, to be able to share that story and talk about how his family plays such a big role in what he does and how his faith plays such a big role. And to your point, he's just got this burning passion that you can feel it. It's tangible. There's a reason that patients travel to see him. There's a reason that patients come down from all across the US to come see him. And it's for that reason. So I think for us to be able to sit down, know him personally and be able to share that story, and, we feel very humbled and have a lot of gratitude for that. And we're excited to be able to share that with our audience.
We absolutely are. So we hope you enjoy this episode with Dr. Jason Cuéllar.
Today, a much anticipated episode. We get to sit down with, I would consider it a celebrity in the spine space. We're really excited to share this one today. Dr. Jason Cuéllar, thank you so much for taking the time. I think this is going to be, a lot of the things that we care about so deeply and dearly, you do as well. And I think you embody a lot of those things. So we appreciate you taking the time today.
Oh, absolutely. Great to see you guys both. I appreciate that.
Absolutely. We're excited to be here, to get to enjoy the Florida weather too.
I know we're back in Florida, which we're never upset about. Yeah. We get to see your practice. And I've heard so many great things. Brady, you guys know each other in the past and we just met for the first time, but I've heard amazing things. So I'm excited to get to share you with our audience.
Oh, thanks so much. Thanks for having me on the show. I really appreciate it.
Yeah, we're excited. We're excited. So you're a guy, 21 years of education and training. That is insane. And so you started your time at UC Davis out in California. You did your undergrad and your PhD there. Did you grow up originally in California, or where'd you grow up?
Yeah, I grew up in Northern California, small town, Redding. So mountain biking, horseback riding, shooting guns. It's a totally different place than the big cities where I ended up in afterwards.
Did that play a role at all in your motion preservation practice moving forward? I mean, you're a very active person out there, being in California and being outdoors and being able to do all those sorts of things.
Absolutely. I mean, I was kind of an extreme sports athlete, I guess you would say. The snowboarding, skiing, mountain biking, and so you're definitely very active. And I definitely, wanted to stay active and would never want to have a fusion at this point. That's for sure.
So when you were starting your undergrad, you went and did your PhD right after your undergrad at UC Davis. When you were in that time period, was your plan always to go into medicine, or what was your thought at that point? Because you're a scientist at heart as well. So I'm curious what that looked like for that transition for you.
So that's a great question. It's kind of an interesting path to medicine that I had. I mean, I guess it was instigated by my own injuries, I would say. So the first thing was I injured my knee during a bike race. And so I tore my ACL. I had to have ACL surgery, reconstruction surgery. And I was pretty impressed by the orthopedic surgeon, Dr. Dillingham. He was over at Stanford at that time, and he was the same surgeon that did Jerry Rice at that time.
No way.
So that was back in the 90s, I guess. And so that whole experience with the surgeon being able to just immediately diagnose my problem and say, okay, we're going to take you to surgery and we're going to fix it. And that was it. It was done. Right. I mean, there was a rehab process that was involved and some pain for sure. But, he was able to identify the problem and fix the problem. And to me, that was, pretty impressive to be able to actually fix someone like that and, make quite an immediate difference. So that inspired me to want to become a doctor and an orthopedic surgeon. And so I sort of pivoted my whole career goals at that point. I was only 20. And I decided that's what I wanted to do. And so then I became razor focused and really motivated to start studying at that point.
Well, you've got such an interesting perspective too, because you're one of the few, you're both a surgeon and you've been a patient. And I think it lends such good perspective, right? To just being on the other side of the table because you're on the other side of the knife at that point, right?
Yeah.
Can you talk about how that has influenced, your time and your behaviors and your beliefs in what you do here in spine?
Absolutely. And that story, that was just my kind of intro to medicine. And the next story, so the following year when I was in college, I was doing something dumb, lifting heavy furniture, and I herniated a disc in my back, my spine, my L5S1. So then I had this terrible leg pain. I couldn't even sit for a college class. I couldn't sit to take a test. I couldn't sit for anything. And so I had a microdiscectomy surgery by Dr. Pasquale Montesano, who actually I work with now 25 years later, which is amazing. So that surgery actually cured me for a while and got me back in the game. And that process really intrigued me. And so then that made me want to become a spine surgeon. And then for my PhD, I wanted to study how a disc herniation actually caused that pain because it wasn't obvious to people. It wasn't obvious to surgeons. It wasn't obvious to scientists, the actual molecular mechanisms. So for my PhD, I studied that. And then I wanted to become a spine surgeon. So then I was on track to become a spine surgeon, or I was motivated to be a spine surgeon even before I got into medical school. So that gave me a completely different perspective throughout my whole training. And then, becoming a doctor, becoming a surgeon, I would say first being a patient and then becoming a doctor. So it was kind of a different perspective on things.
We hear about these stories all the time, and it is incredible. And it's not always an injury where someone is a patient, but just these early life experiences, right? That shape someone's entire, where they're going to be a surgeon and why they want to do it. And I think it's fascinating to hear about.
Well, it's making a difference between a job and a vocation, right? Like you had an experience and then it has to be a vocation if you want to be a spine surgeon, especially if you want to be one that's going to go against the grain of not just, I'm going to put a fusion in every person that I meet, which is, what we're talking about today. So I have a question though. So what is the reason that you have that pain with the disc herniation?
So
what did it
basically
PhD
comes down to inflammation around the nerve root. And, there's a lot of molecular processes going on that I studied, and we still we don't have the answers. I mean, in a PhD, you spend 5 years studying like little tiny parts of that whole process. So at the time when I was studying it, we kind of thought, well, maybe it's a pro-inflammatory cytokine called TNF alpha, and that was one thing that we were really looking at, or the interleukins. And so that education, that study led me to another kind of pathway with a company called Cytonics, where we developed an anti-inflammatory treatment called alpha-2 macroglobulin, where we can give injections into the spine, injections into the joint, and it actually works to calm down that inflammation. And so that's been a whole nother story. And I don't know if we want to get into that today, but
it just talks about the complexities of what you're dealing with here, right? In the spine, how complex and difficult it is.
Yeah, absolutely. I think there's probably a lot of surgeons that don't really appreciate that there is a mechanical component of it, and there's actually a biochemical component to it. And so that biochemical component was what I was interested in my PhD.
I was going to say, that's where the PhD side comes in. If you were wondering where the depth comes, that's where it is. I appreciate that. I've been a back patient myself. I haven't been operated on, but I've had disc herniation. You just think like, it is such a different style of pain, right? I mean, and it just shuts you down, and so I've got a lot of appreciation for that. We'll have to connect afterward. Right? But so you did your process at UC Davis, and then you stuck around at Stanford for medical school, correct? Yeah. And then you actually went across the other coast to NYU Hospital for Joint Diseases. Yeah. And then you came back to finish off at Cedars-Sinai. What were you looking for kind of in your training as you were making those jumps? Like, why go over to the East Coast? Were there certain specific things that you were looking for? Or what kind of migrated your training that direction?
Yeah, that was a little bit complicated too. I mean, of course, you always want to get into the best program that you can. And NYU Hospital for Joint Disease was, top 5 or top 8 or something like that in the country at that point. And there was a complexity of I met my future and then wife, Vanessa, who's wanted to become an orthopedic surgeon as well. So we had to do what's called a couples match. And they had told us at the time, our counselors at Stanford were like, okay, one of you just can't do it because it's not possible. And to both match into orthopedic
Oh
surgery,
my gosh.
like at the same place. And we're like, you know what, we're gonna do it anyway. We don't care what you say. So we just decided we're gonna apply to cities that have a lot of programs. And so that would be New York, Los Angeles, Chicago, cities like that. And we did an away rotation at NYU, and we both really liked it. We did it together. The program liked us. And so that ended up working out for us.
What a unique experience.
Incredible.
And also how stressful. Like the experience alone is stressful. And then to be like, we have to do this together, that's a lot.
Yeah, exactly. It was definitely a stressful process. I'm glad to not have to do that again.
When I saw both you and Vanessa were Stanford to NYU, I was like, that was not by accident. There was more happening
There's a
behind the
love
scenes
match there.
Yeah, exactly.
Yeah.
That's too funny. As you went through that, we see a lot of surgeons on the other side, right? And it's funny kind of how you go down this path based on who you train with. You are huge in motion preservation, as well known as you can be here. And you look at some of the people that you worked with, right? Hyun Bae, Neil Anand, Todd Landman, big names. Can you talk about the influence of just the mentors you had and the training you had throughout that process?
Absolutely. So, back to NYU a little bit, I was there for 6 years, and I worked with some big names there too, Tom Errico, Frank Schwab, but these guys were big, mostly deformity surgeons, right? So they taught me how to handle deformity, they taught me how to put in pedicle screws. We were doing these huge surgeries. And at that time I was like, this is what I want to do. I want to do these huge surgeries. This is really cool, And then when I came out to Cedars-Sinai and I saw that, Landman and Bae, like you mentioned, for example, we're doing these disc replacements, which I hadn't really done at all at NYU. And, maybe, when you're in residency, you don't work with every single spine surgeon. So there are some surgeons that work with the fellows only. And, they were doing some disc replacements, but it was pretty minimal compared to when I got to Cedars, and a lot of spine surgeons, as you mentioned, were doing them. And so working with Todd Landman and Hyun Bae, for example, I mean, those guys are just, pretty amazing mentors. And especially Dr. Landman, I mean, he taught me everything to know about disc replacement. And I think I did probably over 1,000 surgeries with him. I mean, I worked with him for 6, almost 7 years, starting as a fellow and then joining him in practice. And so we did pretty much every single case together. And so learning every single technique that he did was just a pretty amazing experience. And so having a mentor like that was, definitely priceless. And I took everything with me when I came here, basically.
Seeing a disc replacement for the first time, like, did it kind of change your thought on spine surgery? What was that process like for you?
Absolutely. I mean, especially when I saw how patients did afterwards. And, when you do a T10 to pelvis fusion, I mean, sure, you're improving someone's life, and, oftentimes they're falling over, they can hardly stand up, but they're not like going to go snow skiing afterwards or play basketball. I mean, they're not physically high functioning anymore, right? I mean, they weren't to begin with. So you're improving them, but they're not getting to that level, right? Whereas I was watching these patients that we were doing with Dr. Landman as a fellow, and then later in practice, and of course they're not always multi-level. They could be 1, 2, 3 level disc replacements, and they're quickly getting back to, most of them getting back to all their sports and not having any pain. I mean, it's a huge difference. It's a total game changer.
And that's where I think the difference of, like, you're a patient before you understand what that impact feels like.
Yeah.
We talk about it all the time. It's like quality of life, right? Are
Yeah.
you getting to just be like, I'm not in pain anymore? Are you getting to live a fulfilling quality of life?
I think that's an important, I was going to say, I think that's an important mindset shift too. As you talk about, we have this conversation a lot, which is around one of the easy things to measure is pain, right? So we can go in and say, what are your pain levels preoperatively and what are your pain levels postoperatively? But that doesn't always measure a functional outcome, right?
Yeah.
And I'm curious, you've been practicing here not here, but you've been practicing for 10 years now. Have you seen that shift that we're looking at, different metrics or different variables as to what is actually constituting as a successful surgery?
Yeah, absolutely. And, maybe I don't use them in my clinical scenario as much as I should, but we've sort of shifted from like the Oswestry Disability Index or the SF-36 indices and just, visual analog pain scores now to like these, NIH funded PROMISE scores where they try to incorporate psychological function as well as, pain function and how that has an impact on the patient. But I think in clinical practice, I'm more just kind of talking to the patient, how are you doing? Are you doing everything you wanted to do, basically? Are you getting back to golf? Are you getting back to
Mhm.
skiing? Are you getting back to running? A lot of patients after lumbar disc replacement, they're getting back to running. And so most fusion patients, except for maybe like a one level minimally invasive fusion, are not going to get back to running, especially long term.
So we were sitting in here beforehand, getting everything set up, and we were listening to you talk about the care continuum with a patient, right? And
Yeah.
like the different options. I'd love to know you as someone who is dedicated to motion preservation, what you're doing. What is your philosophy on the care continuum? And like for patients out there, what are those options along the
Mhm.
route, right? Because sometimes you don't just jump to the end. There are steps in between, right? Whether it's conservative care or
Mhm.
smaller surgeries. How do you look at that and how do you kind of bring patients through that care continuum?
Sure. So, patients come to me at all different steps along their journey, right? So sometimes, I mean, from one extreme to the other. So, let's say you're a patient that's come in and they've had back pain for, a month. I mean, that happens once in a while, believe it or not. Patient, something happened, they lift something, they come in, they've only had pain for a month, right? So you're saying, okay, now go do some physical therapy, come back in 6 weeks, right? They come back, they still have the pain. Okay, let's try an injection, let's get an MRI, let's see what's going on. So that's one extreme. The other extreme is actually more common where the patients come to me and they've had every treatment you can think of for the past, 10 years, right? They've already had multiple steroid injections after failed physical therapy, chiropractic, massage, every other acupuncture, every other non-surgical treatment you can think of. And then maybe they've had a micro decompression, maybe they've had endoscopic decompression, whatever. They still have their back pain, maybe they still have some leg pain, maybe they have both. Maybe they've had multiple surgeries and they haven't gotten better, right? So that's those are those two continuums, and there's everything in between. So it kind of depends on at what step the patient comes to me at, right? As far as what I'm going to do, right? So if they've had everything already and they're ready for that disc replacement, then that's where we're going to go, right? If they've got a one-sided disc herniation, they've only got a little bit of leg pain, no back pain, then we're going to discuss possible microdiscectomy. I mean, that's reasonable first step, right? If they have degenerative disc with disc space collapse that's significant and they have that small herniation, I'm going to talk to them about the options. I'm going to say, look, we can do a microdecompression, we can do a microdiscectomy, but it's probably not going to be a lasting procedure. It may help a little bit with your leg pain. It's not going to help with your back pain. And I'll give them the option that, right? What if they have disc collapse and they have bone spurs that's causing foraminal stenosis and they've got nerve pain and back pain? I'll say, okay, well, maybe we need to do a disc replacement and turn you over and do a microdecompression, or maybe let's try to do the disc replacement and then see if we wait 3 or 4 months. Maybe we don't need to do that at all. Maybe we can just do the disc replacement. Does that make sense?
Absolutely. I think that's one thing that we have a lot of appreciation for is almost being agnostic
Yes.
to
Mhm.
what you're doing, right? It's that goal setting. And that's something that I'd like you kind of beat me to my next point is how important it is to set the stage beforehand, right? Into what you want to get back to, what you can get back to,
Yeah.
and how long is it going to take, right? Because some people say, I want one and done, right? I want a
Yeah.
surgery I don't want to have to come back in 6 months. And other people say, I want to do as little as possible and I'm okay coming back in 6 months.
Yeah,
And like
exactly.
how important is that stage setting on that front side? Because we just heard you do it and it was incredible hearing you talk through that journey, I think.
I mean, it's super important, especially now that I'm dealing with a lot of patients that are out of state, right?
Mm.
So I don't want them to necessarily have to come back, with a big trip. I mean, I want to try to minimize that. Right. So I'm more likely to try to do everything at once, right? And not say, okay, well, let's wait 3 months and see if your leg pain goes away. And if not, we'll come back and do a micro decompression. If there's a significant chance that it won't go away, I'm going to say, okay, let's do both at the same time so you don't have to come back. Right. as far as setting the stage for expectation, I mean, you definitely have to see, what kind of patient are you dealing with here? Is this someone that just needs to walk around the block without pain and maybe swing the golf club a little bit? Or is it someone that wants to ski, black diamonds in Utah? I mean, that's a different, scenario, right?
Yeah.
I mean, I just did a 3-level lumbar disc replacement on a doctor in Utah that's back to skiing already. And he's skiing at like a very high level. And so had I done a 3-level fusion, I don't think he would be skiing right now, right? So, I mean, that's definitely a different level of expectation. Now, am I promising they're going to get back to that level? No, I don't promise them that. But I say, that's our goal.
Mhm.
Right? That's our goal. I'm pretty sure I can make you better. Can I get you back to skiing? I'm not going to promise that, but that's our goal. That's our hope.
But it's getting back to those functional outcomes, right?
Yeah.
It's like getting back to, we talk about skiing and people hiking and backpacking and biking, but it's also like all your everyday activities, right? Like you're sitting in the car, we talk about like being able to turn your head and look behind you, like, right?
Yeah.
They sound like such simple things until you can't bend down to play with your grandkids or other situations like that. But sometimes you don't know until afterwards, right? And that's kind of the reason we were doing this. And we love sitting down with you is because you believe in patient advocacy and patient education. I think all surgeons do, but you're actively engaging with it so often, but so that patients don't get to where they feel behind the 8 ball and, I already did something that I didn't know about or I didn't know the consequences of.
Yeah, and the level of expectation really varies amongst patients. I mean, I have some patients that are like, look, I want to go run 2 miles without having any pain at all. I want 0 pain, and they're starting off with having a little bit of pain. And like, well, you have to be careful with that kind of patient, because you may or may not be able to help them. And you have someone like me, actually. I mean, at the point that I had my disc replacement surgery, I mean, I was getting to the point where I couldn't even stand up without, terrible leg pain. I couldn't sit down and then I couldn't stand up. It used to be that I could get up and walk around and feel better. But then at the point where I decided to have that surgery, I couldn't even walk without pain. So I couldn't even walk around the block. And some patients are like that. Like they can't stand for 5 minutes without terrible pain. They can't get comfortable in any position. And so I think at that point, you have to do something.
Does that give you, it's interesting as you talk about that, you go through that route, and because I've been there now, you can barely stand up and or walk around, and everyday activities become the heaviest thing ever, right?
Mm-hmm.
Does that give you almost a renewed gratification for what you do and like gratitude for just being able to be around and continue to operate and continue to do the things that you love to?
Absolutely. I mean, not only do I have gratitude that someone was able to help me with that, but I have great gratitude that I'm able to help other people, achieve those very basic goals.
We resonate strongly with that.
Yeah, we're both kind of broken right now, actually, at different levels, which is wild that we've been in the spine space. We have a spine podcast, and then you're struggling with your low back, and I'm struggling with like my cervical spine, and I'm like, turning my head right now is not the easiest thing to do. So, yeah, from experience, we know what you're talking about.
It's so funny, and linked into that, we were talking a little bit beforehand. Go back to that actual surgery when you were with Dr. Landman. I think that is an incredible story with you and Dr. Landman and being on both sides of the table.
Yeah. I mean, it was quite an experience. I mean, I had to say, I had been putting in lumbar disc replacements for maybe 3 or 4 years at that point. And my own pain was getting worse and worse. And I kept seeing my patients come back to me and say, I'm doing so great. My pain is gone. And I was to the point I was like getting jealous. I'm like, okay, maybe I need to, treat myself at this point or have myself treated. And then, I just remember one day trying to walk to my car, and it's only like a block away, and getting terrible leg pain. And I was like, okay, it's time to do it. And so I talked to Dr. Landman, and of course he's just like, okay, jump up on the table. We're going to take care of it tomorrow, basically, and I want you back in work next week. And no, I mean, he was pretty chill about it. But I was back seeing patients in the office 8 days later. And then 12 days later, the first surgery that I did after my own disc replacement was a 2-level lumbar disc replacement, which is actually a pretty physically demanding surgery. And so, I feel like my recovery was pretty quick and smooth. I did, however, get the nerve stretch pain, that's pretty feared amongst patients. I mean, a lot of patients know about it. I think probably 15 to 20% of patients get it after lumbar disc replacement. Comes on about 2 weeks. It can last 3 or 4 months, and it can be pretty brutal. And I did get that. I did experience that. Had to get through that. But other than that, it was a pretty easy recovery. I only took 1 pain pill. And after the surgery, I mean, it was crazy. I went home and had pretty much zero pain. And then about an hour or two after being home, had searing back pain that lasted like 10 minutes or something. And then it went away and like never came back.
Do you have an explanation for like as a spine surgeon?
Yeah.
Do you have an
No.
explanation for that?
No, it was crazy. And then after that, the only pain I really had was my abdomen where the nurse shaved me and like gave me a razor burn. And that was like my most annoying pain.
Oh my God.
I was like, really, you kidding me? I had this like major spine surgery and this is all I have. But I made the grave mistake of not wanting to miss too much work. And I had a little bit of a cubital tunnel issue too. So I had that surgery done in the same week. And so on Monday, I had cubital tunnel surgery, which went very poorly. And I woke up and my hand was weak, like really weak, like I couldn't even like make a fist. And then I had my lumbar disc replacement surgery a few days later. And then like 2 days later after that, I went back for revision cubital tunnel surgery. And then I had to recover from that for 2 years. And so that was kind of a learning situation for me. I'm like, you know what? Probably better to avoid more than one surgery in
It's a lot for the body. Yeah.
Yeah. So that was kind of a bad decision on my part, but the disc replacement surgery went great.
Want to circle back to that. That's funny. So, and that was at the time when you and Dr. Lamb were partners. You were out in California. You know, now we're sitting here in Palm Beach Gardens and, you know, pretty much across the entire east coast of Florida here from Miami up to Jupiter. You have clinic.
I love South Florida at this
Oh
point.
my gosh.
Yeah, it's great. I mean, the people have been great. I actually like the weather. Beaches are amazing. Everything's going great. You know, I'm surrounded by good people and we're building a new surgery center in West Palm Beach. It's going to be done by the end of the year. So I'm very excited about that. You know, we're going to have basically a center of excellence for disc replacement. So super excited.
That's incredible.
Yeah.
And you have such a unique practice. I think we were talking before we started that I think you said like 90% of your patients are travel patients that come to see you. Talk to us about that. How do you end up with a practice that many people are going to come and see you?
Yeah, it's pretty crazy. I mean, before I moved here, I basically just did a little bit of online marketing and I had a reputation nationally for disc replacement. And so when I got here and patients were finding me online and then they're living in places around the East Coast where they don't do much lumbar disc replacement or even much cervical disc replacement. I'm talking about New York, the Carolinas, Virginia, Atlanta, Chicago, those quite a few East Coast cities actually where they're not doing much lumbar disc replacement or cervical for that matter. Mm-hmm. So the patients are finding me, they're coming to me for this procedure because I'm well known for it. And so definitely a different practice than I was used to before. So you know, we made some adaptation, but things are going great, and so far patients seem to be pretty happy with how things are done.
It just speaks to how much patients are just like searching for a motion preserving alternative. That they're like, I want to stay in motion, willing to fly somewhere to get surgery. Like that's a big decision. Just getting surgery alone is a big decision. And then say I'm going to jump on a plane and go somewhere else to get it. That's huge.
Yeah, I mean, I see patients every day who have seen multiple surgeons and they all say, oh, you have to have a fusion. You have to have a 2, 3, 4 level fusion. And they just don't want it, you know, because they know the consequences of that.
And I think that's a great point. I'd like to ask you, because we've talked about this previously, you know, cervical disc replacement is pretty well adopted. It's not everywhere, right? But I mean, a lot of folks are doing it. But lumbar disc replacement, there is a lag. And sometimes you get the question of patients asking, why does everybody not do lumbar disc replacement? I'd love to have you answer that question.
Sure. So it's a very complicated answer and there are multiple reasons. I think probably reason number one is just lack of training. So in their residency and fellowship, they just weren't trained how to do it. And it's not the same. It's really not the same as doing a fusion. There's a lot of technical challenges that you really need to learn how to handle. And so that's number one. I think number two, not having a really good vascular access surgeon. I mean, even in Los Angeles, there are centers, I don't want to say names, but there are centers where the access surgeon will take 2 hours to expose one level. Whereas the vascular surgeons that we're using at Cedars-Sinai and the vascular surgeon that, you know, thank God I have here is amazing. I mean, he can get me L5S1 access in 10 minutes or less. And, you know, 2 levels takes him like 15 minutes at most, safely. So, and he's an amazing surgeon, cardiothoracic surgeon. So I think that's a number one. Those are number one, number two reasons. I think the next one is probably kind of a reason that most patients don't want to hear, and that's insurance. And there are multiple problems with insurance. One thing is insurance often will not authorize it. And there's multiple excuses. I say excuses that they come up with. One is age. So they'll say, oh, the patient's over 60. They want, they're not allowed to have lumbar disc replacement. And that's just the insurance company playing medicine, basically, or trying to practice medicine. Another reason the insurance company won't authorize it is it's, more than one level. So they'll say, we only approve one level. That's Aetna, for example. And don't ask me how Aetna got away with this, because there was a class action lawsuit against Aetna when they weren't covering lumbar disc replacements. Actually, one of my patients in Beverly Hills headed that class action lawsuit because they weren't covering it at all, and he needed it. And so Aetna lost the lawsuit, and they're supposed to cover lumbar disc replacement, but they only cover one when everyone else is covering two, and at 2 levels FDA approved. So I'm not sure how they're getting away with that. I'm sure they're going to get sued again, and hopefully they lose the next one as well. So that's another reason is insurance companies are saying, okay, we don't cover it at all, or we only cover one level. And then certain levels they won't cover, like, they won't cover the L1-2 or L2-3 just because they say, well, that wasn't included in the randomized control trial, so we're not going to cover that one either. So the other problem, and this is the worst reason, and surgeons don't want to hear this, patients don't want to hear this, but unfortunately, surgeons are paid less for disc replacement by a lot of plans than they are for fusion. And so that's a really bad reason. And hopefully, not a lot of surgeons are using that as a reason, really, but that is a reason. And another reason is, some patients are really aren't candidates for it. So I understand that. I mean, that's fair. Some patients have instability or bad scoliosis, degenerative scoliosis, so those patients truly can't have it. So that's actually a good reason for not having it. But I think that the other reasons are really should and can be overcome eventually.
It is frustrating how much an insurance company can be in the OR room where they don't have any right to be in there.
Yeah.
And that dictates so much of what patients are offered across the country, right?
Yeah.
It is so frustrating. And I think it is, like, we talk about that all the time. It's like, that's crazy that an option that can get you back to life more and quicker isn't covered, but then a fusion is. And like you say all the time, well, do you have the data of the fusion, multi-level fusions? Like, we didn't have that when it was covered, right?
Exactly.
So it's not a fair playground. Yeah.
I always think that's fascinating. It's like, did you run a 5-level fusion study to show that that's like reimbursed? Like, no, but we reimburse it, right? But now a 2-level disc replacement is a problem.
Yeah, or even 3-level ACDFs.
It's unbelievable.
Right? I mean, that's a very standard surgery for a lot of surgeons, but yet they don't want to approve a 3-level cervical disc replacement. Which to me has way better outcomes, is way better for patients than a 3-level fusion.
It's so and it's tough for patients because, patients, it's easy to quickly assume that, oh, well, if this thing is not standard of care, is not done all the time, or insurance is choosing to not reimbursement, therefore the data or the outcomes must be worse, right? But it's easy to make that leap, but until you're in the weeds, you don't realize how complex and multifactorial that is, right?
Yeah.
I mean, there's so much that goes into it. And you made a really good post about this too, where you talked about insurance, denial and the claims of this is not medically necessary. Like, who are you to tell me that this is medically necessary for my patient?
Yeah, exactly. Medically necessary just means we don't want to pay for it.
Exactly.
I mean, basically, I told a patient this the other day. I said, look, it's my job to do what's best for you and to get you better. It's the insurance company's job to make as much profit as they can, because that's what their board is holding them responsible to do, right? So it's their job to make money. So how do they make money? They collect premiums from people and they deny as many claims as they can. That is their job. Their job is really not to do what's best for the patient.
You have these conflicting incentives that really is so frustrating. And it makes no sense to me that the surgeon wouldn't be the one that always wins out on that spent their life training and making these decisions, that wouldn't be the final say. It's something we definitely have to work on in this country because it's ridiculous.
Well, you talk about this, it's almost like the hurdles or the barriers to entry, right? Like, even for a surgeon who says, I would like to adopt this technology, the learning curve is longer. You have to go get someone that trains in that. You should be putting in more than one a month, right? Like it's something where specificity matters. There's a higher hurdle to entry. And then you go do all those things and you get reimbursed less. It's like, well, what's my, like, and again,
it's hard to say that,
right?
yeah.
Like, and then you look at it and you say, well, most surgeons are doing this for, the good, like they're giving to people to make people better, right? And they believe that they're doing, but when you've got all those hurdles and then what you get back is less, it's like, well, why would I go through all those hoops to do that thing, right? It's just the incentives are completely backwards.
Yeah. And every time I do like a really, really bad lumbar spine, I do, last week I did a really degenerative 3-level lumbar disc replacement. And man, it is so much work. It is so difficult. And, at the end of the case, I'm like, man, it'd be so much easier to do a fusion. So much easier.
Right? The precision you have to do that compared to a fusion.
Yeah.
Like you should be paid way more doing that than a fusion.
And to get paid, the in-network rate for that is just ridiculous. It's absolutely insulting to surgeons.
I think it's such an important conversation too, just so patients have an awareness of what's driving some of those, right? Because there are so many factors that go into how all that works, right? And what ends up on even what's available in your area, because a lot of times you go to 5 different surgeons, but if you go to them all in your area, there might not be one that is offering, like to your point, you might have to fly to Florida or California or somewhere else to get that care, but you would assume that the best care is available where you are.
Well, and that's exactly why you've made a successful practice where you are, because you're filling a gap that is very hard to find in this country, right?
Yeah, and what's super frustrating, is when I hear patients tell me all the time that their surgeon told them that they can't have a disc replacement because of XYZ. They have too much facet arthritis or the disc space is too collapsed. It's just not true, And so I'd much rather the surgeon just say, look, I don't know how to do lumbar disc replacement, so go find a surgeon that does it. Don't tell the patient you can't have it or you shouldn't have it or it has worse outcomes or and I've heard every excuse under the sun for why they shouldn't have it, and it's really frustrating on that end as well.
And it's a hard thing about ego, right? It's hard to swallow that sometimes, and you have to have ego to be a surgeon to an extent, like to feel confident and go in, and you want your surgeon to have some ego to be like, I'm going to go in and fix this. But there's a double-edged sword with that of like, can I also be able to admit when I'm not the right person for this patient, but their life continues even when I'm done? And am I giving them their best quality of life moving forward?
Absolutely. But I mean, I think it's something that all surgeons should learn how to do. I mean, I was talking to a patient earlier today and I said, look, an endoscopic surgery may be the best for you. And I don't do those because I don't want to learn how to do that. So I'm going to send you to someone that has learned how to do it and is very good at those, right? And if someone comes to my door and they have a huge scoliosis, I don't like to do scoliosis anymore, so I'm not that good at it anymore because I haven't done a scoliosis fusion in 4 or 5 years, right? So I'm going to send them to someone that does that regularly, because volume of any sort of surgery is much better. I mean, outcomes of any sort of surgery is much better if you are a high volume surgeon. So for example, like when you look at total joint replacements, they've looked at centers that do very few joint replacements versus centers that do high volume. And the high volume centers have much better outcomes than the surgeons that just sort of dabble in that particular surgery. So the same thing is going to be true with lumbar and cervical disc replacement. If you have a surgeon that just does them once in a while, I think the outcomes are going to be questionable versus someone that's doing them regularly.
That's something we love so much, is that exact concept. And it's funny, the point, you beat me to the point. We were listening to you offer up other options for this patient when you were on the phone. And I think it's like, that's one thing that we've loved to do so much is now, 20 episodes in, we regularly get patients that reach out and say, I'm looking for this type of procedure, or I've got this problem, right? You can start to find the right people for them, right? Like, oh, maybe New York is right. If if you're that deformity, you've got that major deformity, that scoliosis. If you're looking for motion or disc replacement, it's different, right? Yeah. But to be able to start to connect those dots and get people to the right places, I think is so important.
Well, and it's so confusing and scary when you're a patient because it's not clear out there. It's very hard to understand, and you have all these forces kind of working against you where you're like, I'm in pain. I don't know what to do. I don't want surgery. Most people are like, you want that to be your last option. But in a lot of the country, fusion is the first thing you're going to be offered. And patients just innately know they don't want that. They understand of like, that doesn't feel natural to my body, or they know somebody who's had one that it wasn't successful. But then to be able to find the right surgeon or that will walk you through it, one, just to figure out what's the best thing for me, but then also to potentially go on that insurance journey with you to either work through that or be financially in a place where you can just pay out of pocket. It's just so difficult to handle.
Yeah, I do feel bad for some patients. I mean, they're being told multiple different opinions. They don't know what to believe, right? Because they're seeing multiple surgeons and who are supposedly credible surgeons,
Yep.
right? And they're telling them, you need this, you need that, you need that. And if they're getting 5 different opinions from 5 different surgeons, it can be very confusing. And that is one problem with spine surgery. I mean, there is more than one way to do
Mhm.
certain things, right? I mean, let's say a patient does need a fusion. You can do a fusion in 3 different ways, right? You can do an anterior lumbar interbody fusion. You can do a direct lateral interbody fusion. You can do a posterior lateral fusion. You can do a transfemoral lumbar interbody fusion. You can do T-lift, right? So there are multiple ways to do the same thing, multiple ways to do a lumbar fusion. Which way is the best? We don't have great evidence that one is particularly better than the other for everyone, right? So it can be confusing even for the surgeon sometimes.
Mhm. Well, and to your point earlier, it's like what's probably best is whatever I'm used to doing most in my hands.
Yeah,
But at what
exactly.
level do you allow that to be the answer versus there's something else that I can't do in my hands, it's time to hand over to somebody else?
Yeah, I mean, you can't be the best at everything, right? So I mean, I think you need to learn how to do certain things, and you need to be able to recognize when something else that you don't do might be better for the patient,
Mhm.
and appropriately send the patient out.
And we're going to be at ISAS tomorrow, and everybody who does those specific types of procedures, every person will say that procedure is the best procedure, right? Whatever they're doing is the best procedure, right? It's tough to sift through. I want to talk a little bit more about your work. We've talked about lumbar. We haven't talked about cervical as much,
Yeah.
but you also do a ton of motion preservation work cervical, and not just 1-level cases, not just 2-level. I see 3-level, I see your 4-level case, I see your 5-level cases. You're a pioneer in that regard. Talk about how you're able to do that, and you go forward and kind of push the bounds into what is possible and what you're able to provide to patients.
Yeah, I mean, I have to give a lot of credit to Dr. Lamon in that sense, because I think we really pioneered some stuff together. Like for example, fusion reversal. We published the first paper on fusion reversal surgery for cervical spine, and we had patients that had a failed fusion, and we were able to cut that out and put in a disc replacement. So other surgeons think that's pretty crazy, but I think in certain situations, it's definitely better than the alternative, which is to go in the back of the neck and put in screws, or just try to do the same thing all over again and hope for a better result, right? So, that's one aspect of it. Um, it's just been practice, repetition, and trying to get better and better, and trying to make little tweaks and improve upon what we've been doing all along, basically. And along the way there have been different implants, right? So now we have like 8 or 9 different cervical disc replacement implants on the market, and I've used them all, and trying to figure out which one is best in certain situations and which one is never good.
It's such a good point, though, to someone that does this so regularly and so often. You can actually decipher based on someone's pathology and even their biomechanical nature, right? What implant you should use in each situation. Not just that you could get a disc replacement, but there are different options, right? And so some folks don't even have that opportunity, right? Is you just have the chance to get a disc replacement. Here you can choose between
Yeah.
what you think is best for the pathology.
Yeah. And there are some surgeons that don't do that many, and then they choose one disc replacement, they'll only use that one implant. Some surgeons start off with an OBC and they never want to change, and there are problems with that implant. They're not willing to try other ones. And, I mean, it can be scary to try a new implant, but I think that there are definitely some benefits of certain implants over others in certain situations.
What's your philosophy? How do you decide?
I decide based on the patient. So for example, I'll give you a few scenarios. So overall, I like the Pro Disc for almost everyone. I think the biomechanics are really superior. I like the fixed mobile core. I like the keel device to be able to give you immediate stability. I like all the different size options. but its one downside is made of cobalt chrome, and so to get a post-op MRI is not that useful if you want to look at that level.
Mm.
So if a patient has pretty bad spinal cord compression and myelopathy, and I need to make sure afterwards that I've done a 100% perfect decompression, and I need to get MRI afterwards, then I may lean towards something like the Simplify, which has a much better post-op MRI capability, even though I may not like the implant biomechanics as much, right? If someone has a known nickel allergy, which is pretty uncommon, then I can choose between, it used to be the M6, or the Prestige LP is ceramic and titanium, there's no nickel in it, or now I can choose the Simplify, but I wouldn't necessarily choose the Pro Disc, even though that's normally my favorite disc. It does have a tiny bit of nickel, so I'm going to avoid that if I know for sure that they have a nickel allergy. If I'm going to do a revision disc, I'm almost always going to go with the Pro Disc. I think the size options are the best. If I'm going to go next to a fusion, I definitely want that fixed mobile core, so I'm going to go with the Pro Disc. And then now the Pro Disc has multiple different options. So they've got the Vivo for the very curved end plates. They've got the original Legacy, which is flat, and they've got the SK, a short keel. So if I'm going to go next to a plate and I don't want to take off the plate, then I can use the short keel device, right? So there's a lot of options that I can use during surgery without bringing in other companies when I'm using the Pro Disc.
I absolutely love it. You know, we talk about these multi-level cases, and you started to talk on these other topics too, right? Which is fusion reversal, which we don't see a lot of, right? We do not see a lot of that. And we talk about hybrid cases, right? Next to a fusion, where people are kind of starting to almost try and protect adjacent segments, right? Where you're getting some mobility. Can you talk about that concept a little bit of, you know, where you're starting to use these in different scenarios that maybe, you know, what you'd consider an off-label use or things like that nature?
Sure. So, you know, once in a while, I'll do an actual hybrid primarily if, let's say, a patient has a really bad segment where they've got cord compression, ossification, and I can't safely do a disc replacement, but they've got degeneration above and below it. That's a perfect case for doing a fusion at one level and then disc replacement above and below it. And then that way I'm not worried about adjacent segment degeneration, right? I've already protected those levels, right? I mean, I'm not going to do that with a totally normal disc, but if they have degeneration, which I think is causing some symptoms, and then that's the option to not have to worry about in the future coming back for the adjacent segment. What I do most commonly is a patient comes to me and they've had a 2-level fusion or a 3-level fusion 5 years ago, and they're already back for more surgery because you guessed it, the level above and or below is trash now because of adjacent segment degeneration. So commonly I'm doing a disc replacement above or below an old fusion.
It's stuff that we don't see a lot. So it gets exciting when we can talk about these things. And CM, you've got this incredible post for people that follow you. I believe it was a lumbar case. I think it was a 5-1 case. Someone that was fused for 7 years. And you did a live fluoro shot and showed the space actually moving after you did a fusion room. I mean, it is incredible because essentially people say it can't be done, right? Or it shouldn't be done. And you can see that you can remake it mobile again.
Yeah.
And you talk about the facets being mobile too. It's like the fusion is not there forever, right? Like you can get some mobility back from that.
It's very interesting. Dr. Lamman loves to say, the facets just kind of sit dormant. They don't actually fuse usually. Sometimes they do. I mean, that's why, we always check a CT scan. And if they're sort of spot welded, then you're not going to do that, right? But most often than not, when the disc collapses, it just stops moving and the facet joints just kind of sit there and they don't degenerate. So most commonly, we see when patients come in, they've got multi-level degeneration. Most commonly, let's say 5, 6, 6, 7 wear out first. Those are fully collapsed. They stop moving. And then the one above it, the 4, 5, gets hypermobile. And that's the one that gets a spinal listhesis, trashed facet joints. But the 5, 6, 6, 7 that collapsed first, those facet joints are usually like normal. So as long as you have the skill to open up those disc spaces, you can get full mobility afterwards. And that's where I think a lot of surgeons do the patient disservice and they say, oh, the disc is too collapsed. You can't do a disc replacement. Yeah, you can. You just have to know how to do it. Right? So that's the problem.
I'm curious the recovery of something like that after. Is there any, because you have movement that hasn't been there for a long time, is there a difference? Is there a bit more pain at first, just the body getting used to moving in a way it hadn't because it'd been fused? Some
people do seem to have, some immediate post-op neck pain, but it's not everyone. I mean, that's kind of not predictable in my hands. I mean, it seems like a lot of people that were really collapsed, and I, really stretch them open a lot, and they'll wake up and they have no pain, and I'm like, I'm shocked, and other people have a lot of back pain, or neck pain. It definitely varies, and it's hard to predict that.
And everybody's a little different, right?
Mm-hmm.
Recovery rates, some people feel fantastic, 3-4 hours later are ready to go. And then, some people take a little bit longer. It's just kind of part of the process. As we're talking, there's something I want to talk about. So we've talked about a lot of different technology. We've talked about you being a pioneer. There's technology we know well, MOTUS from 3Spine. You've talked about it. It's, you got a bilateral approach that's posterior instead of coming anterior. One of the things that I want to talk about, and I'm curious what your take is being able to have a posterior approach for motion preservation, and what that offers to patients and what that offers to surgeons, right? Because we talk about some of these hurdles, right? And an access surgeon is one of those things, right? So coming anterior. Yeah. So talk a little bit about that. And, it's in the data collection phase, so it's going through the clinical trials. But you know it well, and I'd like to have you just talk a little bit about that in that process.
So this is going to be an absolute game changer. I mean, this is going to change the world of spine surgery around the world. This is going to be absolutely amazing because, as we mentioned before, there are a lot of patients that currently can't have lumbar disc replacement in the traditional way because multiple reasons. That there's no vascular access surgeon. Maybe they've had anterior abdominal surgery before. They have scarring. They can't get there. Maybe they're a bit overweight. We can't reach it. Maybe they have really bad facet joints. They have some instability. There's a lot of reasons why they can't have, good reasons why they can't have lumbar disc replacement in the way that we do it now. A lot of those patients will now be able to have disc replacement once that MOTUS device by 3Spine is available. I think it's going to be a game changer. The only thing that worries me is I think it's technically difficult to do. Like the carpentry work, I think you've got to be an excellent surgeon to do a good job. So I think we're going to have to do a good job at training surgeons. But I think if we're able to do that, it's going to be a game changer.
Absolutely. And we talk about that too. So you've got the first total joint replacement for the lumbar spine, right? We've got total joints for our knees and our hips and our ankles. Now, hopefully we'll have one that's replacing both the disc and the facet. But to your point, it's just like motion preservation in general, right? Like the training has to be right, and you have to get it dialed in. And there's like anterior discs. I'm sure there's some amount of learning curve. How many cases do you think it is for, if you're going to do a lumbar disc, what would you tell a surgeon the learning curve is?
I mean, to be really good at it, I mean, I feel like it took me at least 50 cases, maybe 100 cases to be really good at it. To be proficient at it, to really be comfortable knowing that I'm doing the right thing. Because the basic case, like a basic mildly collapsed disc, I mean, that's relatively easy to do. I think most surgeons can do that. You can learn how to do that pretty quickly. But I think it's those collapsed discs. It's certain situations where you have a little bit of retrolesthesis and you're not sure exactly how deep to put it. So there's some nuances there that I think take a while to really get comfortable with. But I think just the basic techniques you can learn pretty quick. I mean, I think maybe 20 cases you might feel okay with it. But I think the more complicated cases, the multi-level cases, more like 50 or 100.
And then you learn what you can do with it and what cases it works in, right? But there's that learn. I mean, that's new technology for anything, right? Adoption. I mean, we see that in endoscopic is a great example, right? Exactly to your point is like, I don't want to go and learn. That's a whole new skill to learn. Yeah. And the time that you're taking doing that is away from something else.
Yeah.
Right?
And the thing is that you don't want your surgeon learning on you, right? When it's something that's really high stakes. Yeah. I mean, endoscopic is bad enough. I mean, but that's really not as high stakes. I mean, if you don't do a perfect job removing the bone spur, you can go back and do it open. You can do it again. If you mess up a lumbar disc replacement and it's way off center or not deep enough or too deep, or you don't lock in the poly right, or you make an error, a surgical technical error, I mean, you can't always get back to that, right? You can't because there could be scarring in the vein, and so you need to make sure that that's done perfectly every time.
Which is why it's important when you're a patient to ask those questions of how many times have you done this? Do you specialize in this? I think in orthopedics, you specialize. I do hips, I do knees. You go to them for that. I think there's a place where I do motion preservation. I do discs, or I do total joint replacement. That I think is an important aspect as we continue to have innovation and have new technology. To your point, you have to have precision and you have to be really good at it. And that learning curve is something we have to consider if we're going to provide it to patients.
Yeah, and we have to continue teaching. I think, Sentinel Spine has done a very good job of surgeon education, and I've taught several of their pro disc courses where we have surgeons coming from all over the world, and they get to hear us talk about it from an experience standpoint, and then do the cadaver lab. But of course, I feel a little bit mixed about that because I'm like, well, that's not really enough to then go out and do it, right?
Yeah.
So I do host a lot of visiting surgeons actually that come and watch me do disc replacement in the OR. And, I probably had at least, 5 or 6 surgeons come to Florida in the last, several, 6 months or so. And, scrub in with me and actually, watch the whole surgery, several surgeries. I think last week we did 7 pro discs or something in one day, and had a surgeon come in and get to watch that. So I think, stuff like that is definitely useful for surgeons to help them to adapt it. And then after they leave, they'll send me cases and say, hey, what do you think about doing it? This and this. And I always recommend that they start off with the easy cases first and, get the experience
build from there
that way.
Yeah.
But it's definitely difficult to take on a new technique, especially when it's high stakes. And that's, of course, one of the reasons why there are a lot of surgeons that don't do them, because it's hard to get into that. So, I think I was really fortunate to be able to train at a place like Cedars, where during my fellowship, I got to be involved in probably a couple hundred disc replacements just during that 1 year. So that was an amazing experience.
The concept that we get excited about is adding something to your arsenal, right? And that's something I'd like to talk to you about as well. We talk about cervical disc, we talk about lumbar discs, lumbar total joint replacement. It's just these technologies that add another alternative for motion preservation. You were talking about Intracept earlier, right? A non-instrumented procedure that you can go is considered motion preserving. That's one point we haven't touched on. I'd love to have you touch on non-instrumented procedures. You can have non-implanted motion preserving procedures as well. Can you talk about those and how those kind of fit into the continuum as well?
Yeah, there are a lot of patients that need an actual microdecompression. They have foraminal stenosis or nerve root impingement of some sort, or paramedian disc herniation that you can treat with a surgery that's not it doesn't require an implant, obviously. And then there are your pain management procedures, your radiofrequency ablations, which I think are overall not that useful, unless it's a facet joint mediated pain, which I think is not as common as a discogenic pain. But that's along the continuum. And then we mentioned earlier, I think endoscopic microdecompressions, I think those definitely have their place.
So there is another thing that I want to talk about. You produce patient education and you have so many patient testimonials. It's incredible to see the patient testimonials that you have. There's one in specific I'd like you to talk about. Your jiu-jitsu fighter, Brandon, a 3-level disc replacement. And this talks about what people are able to get back to do, and watching him back on the mat and train. Can you talk about that story? Because it was so powerful for me to watch a 3-level lumbar disc replacement. Like it just shows what Sentinel does and what motion preservation can do for a patient.
Yeah, I have a handful of patients like that are just these home runs, right? You just hit it out of the park, and of course you don't hit a home run every time. And I wish I could, right? And so that, coupled with the fact that Brandon is like a superhuman person. Literally he was like state champion for Florida for like some body heavy lifting, what do you call it? Weightlifting, powerlifting. So not only is a black belt in jiu-jitsu and he's an instructor in jiu-jitsu, but he's a state champion powerlifter, right? So he's super, super strong. It's like superhuman strong. So I think, going into the surgery with that level of strength definitely helped his recovery. And then he's so motivated, to get back to that level, right? But he's just such an amazing example of someone that was, living for several years at a level of pain where he was getting by, but just very guarded in his activities. He was still doing jiu-jitsu, but not to the level that he was used to be able to do. He was not even teaching it to his students. He told me afterwards, he's like, look, I was avoiding a lot of maneuvers, and it felt like he wasn't teaching to the best of his abilities. And he said, even picking up his kids, he was having trouble doing. And so he felt that he was, not living his best life, right? And so, thank God that the surgery did for him what he wanted to do, which is get him back to full 100%, everything. And I hope that it lasts the rest of his life. I mean, we'll have to wait and see. But stories like that are obviously, that's why I go to work every day.
Mm.
And for patients that are watching, it is such a powerful video to watch. Like he is sparring on the mat. He is rolling. Like to watch someone do that and to go through those paces. I mean, if you're going to test a disc, like that's the way to do it, right? It's incredible to watch what he gets back to.
Yeah. Well, his case actually tested, tested my experience as well, because within a couple months after surgery, he started sending me pictures of him. Well, maybe it was like 3 or 4 months after surgery. He was sending me pictures of him. The first one was a picture of him leg pressing. He was leg pressing like over 500 pounds. And I was like, whoa, how many plates? I was like, wait a minute, how much weight do you have on there? And so I started to worry. I was like, man, is that okay? So I started to really worry about the limits of the implant, because I never had anyone before that was lifting such heavy weights. And so I started to really worry, like, what are the limits of the implant, right? And then, so, I reached out to Dr. Marnet in France. I talked to Dr. Landman. I talked to Dr. Hall out in Flagstaff. And luckily Dr. Hall actually talked some sense into me, because he was like, oh, it doesn't matter, the leg press, because all the weight goes through the femoral heads and the acetabulum. It totally bypasses the spine. And I was like, duh, I thought about I was like, why didn't I realize that? All these other surgeons were like, oh yeah, let him do this much, not that much. And I realized, like, actually, it doesn't matter. I was like, but it does matter how much he squats, right? And so I was like, okay, how much can the L5? And I'm mostly worried about the L5S1 disc replacement, because that one has the shear force, right? So Brandon has a pretty flat sacral slope, so he's at a lower risk. But I went back to the pro disc shear failure studies, and I looked at those, like the failure at 45 degrees was, I don't know, like 2,000 newtons or something. I calculated out, how many pounds that was. And, I can't remember exactly, but it was quite a bit. And so I was like, that made me feel a little bit better. But I told Brandon, I was like, look, I'm really not sure. I'm really not sure how much weight this can take. So, leg press is okay. Go to town, because he's like, it feels great. I'm doing 500 pounds and it doesn't hurt at all. My back feels great. I'm like, oh, okay, well, I think that's okay. But, and he's sending me pictures of him doing these other, weightlifting things. And I'm like, that may be okay. That I'm not so sure about. And so he's kind of testing my limits as well, as far as experience and what's okay and what's not okay. Because I certainly don't want someone like him to fail from such a such a high level.
Mm-hmm. That's what Courtney and I have both had injuries, and usually I'm telling you, get out of the squat rack, right? You can't put the 500 pounds down.
I'm also a power lifter. I know you can't tell, but
I'm a power lifter
every weekend. Yeah.
I want to talk about something that I don't think gets talked about as much. You brought up a really good point on, I love how you go back and talk about the biomechanics, and you're looking at the shear forces and truly understanding what the device can do and how the body moves. We see that a lot on the surgeon side. I think we talk a lot about the care team in the room, right? We talk about nurses and, anybody who's on the table, first assists and rad techs. Something that doesn't get talked about as much, reps and clinical specialists. Mm-hmm. And you work with some of the best.
Yeah.
I know Blake very well. I know Ryan very well. They're taking over Florida. Can you talk about the importance of having somebody who understands what's going on and how that can truly help in the room and how big of a role they play?
Absolutely. I go back to my days at Cedars-Sinai, where Dave Baird, had probably been in the room for more lumbar disc replacements than anyone in the country, I bet. And, so getting experiences from him, he's taught me some tricks, like when doing revisions, getting them out if I had to get them out. And so it's definitely important. And, with my guys here in Florida, I'm definitely happy with them as well. They have seen enough cases now where they know, they can offer up some tips if there's, certain situations. And I think that not only is it important that they interface with the staff and make sure that they're putting the implant together properly, that they're putting it on the inserter properly, that they're giving me the right instruments, that the right instruments are in the room. Those guys are those guys have been instrumental to me coming to Florida because basically, I set up shop at multiple different places. I've now privileges and multiple surgery centers, multiple hospitals here. And each time I went to a place, I had to give them a list and say, these are my instruments, and unfortunately, no other surgeon uses them. so, like the microsec curettes I use, these microsec keratin shavers I use these weird things that no one else uses. And so, Blake and his team have been sort of hunting them down and bringing them to every single place that I operate at and making sure that they have them. And Dr. Lamon and I even developed this custom intradiscal spreader for cervical ADRs. We don't use Caspar pins. So 99% of surgeons use these things called Caspar pins that you screw into the vertebral body and you put this spreader on it and it sort of holds the disc space apart. I don't use those at all for multiple reasons. For one thing, they put holes in the vertebral body, which I don't think is ever a good idea when you're doing a multi-level cervical disc replacement. Another thing is they actually hold the disc spaces apart at whatever angle you put the pins in. So if you're not perfectly parallel with your pin placement, then what's going to happen? You're gonna get some rotation that's forced, and it's going to be held in that position, which I think is not the best idea for a motion device, right? So I want like a natural motion, a natural spreading to occur during the disc replacement insertion. So I don't use Caspar pins. So we have these special so originally Ralph Cloward, a neurosurgeon, I don't know how many decades ago, designed this little spreader. It's like an A-frame spreader that's old school that we use initially. Dr. Lamon taught me how to use that as well. I mean, he taught me everything, right? So all these kind of weird techniques that no one else uses, I learned from him. And then at some point we improved upon that thing. So now we have this custom spreader, which I think is better than the original Cloward spreader. So Sentinel actually makes it for us now. So I have to have that at every single place that I go. So, Blake has been instrumental in helping me. And actually, since I've been here, we've made some more improvements on that device. So
that's incredible.
Now all the surgeons listening are going to want one.
I was just going to say, yeah, you got people reaching out.
Yeah. Blake has complained a little bit because I showed the surgeons that, so there's a special lumbar spreader that the Sentinel made, and I got to use it. I think first, and I think they have a couple of them, and so every surgeon that sees it is like, I want one of those, and they're like, sorry, we only have one of them right now.
You got to protect those guys at all costs. Yeah, protect them. They're fantastic. I mean, Blake and Ryan are fantastic, and just like the aid, and so you're with Sentinel, right? And Josh Ruth is one of the most well-versed, well-educated in motion preservation that there is, right? And I think it's so inherently important to have those folks. As you look back, you talk about these little tweaks that you make and these little improvements that you make. You've been practicing 10 years now. What's the biggest change that you've seen or you've made, to improve those motion preserving cases? And I think you probably learn from what works and a little bit from what doesn't, but what's the biggest change that you've made, like in your own practice, as you look at those motion preserving cases?
I think with the cervical spine, it's been kind of evolution for me as far as implants. I mean, I learned initially on the Pro Disc and then went to the Prestige. And then put in a couple hundred Prestiges, and then we went to the M6, and then kind of circled back to the Pro Disc. And so I think that evolution has kind of taught me some things about implant placement, center of rotation, where it should be for most implants. But I think the most important thing I've learned, I'd say, is the actual foraminal decompression. And that I learned from Dr. Lamon, and that I think you have to do regardless of implant. And, basically that's just a technique that a lot of surgeons are kind of afraid of doing adequately, because as you go further out into the frame and you get closer to the vertebral artery, which is a scary thing. But I think I've learned that, even though I'm pretty aggressive at doing that, I still have had a number of patients that I've had to bring back for a wider foraminotomy because I didn't go wide enough. So I've really learned that with disc replacement, you have to make sure you do that wide foraminal decompression in the neck. I'm talking about cervical spine. Whereas if you just do a fusion, you do ACDF, you don't really have to worry about that as much because you're stopping motion and usually you're putting in a big enough graft to where you're giving them that indirect decompression, and you're not worried about that as much. So I think that's one thing that I've really learned is to be more and more aggressive with that foraminal decompression. And the other thing I'd say is I've kind of circled back to the keeled device as well. I think that I have seen some migrations with the non-keel devices. I mean, they can be good in some people, and they usually work. But when I've come into a problem, it's usually with the non-keel devices. Um, and then when it comes to implant materials, you know, um, I'm sure the M6. Well, it's off the market now, so I'm not sure I can cause any harm here by talking about it. But it's probably related mostly to infection, but they've run into a lot of core failures. The core basically disintegrating, and every single one that I've seen, it's been related to infection. And I'm not sure what comes first, but I think that the bacteria are probably in the disc space, in a degenerative disc, and then that particular core, it's like a rope that catches the bacteria and then gets destroyed. And so I think that when I look at different materials, I definitely learn, what to trust more than others. Like initially when we started putting M6, everyone was like, "Oh, this is amazing. It's compressible. It's just like normal biomechanics. It's going to be great." And so I started using it, right away. And now when a new implant comes onto the market, I'm a little bit more leery. Like for example, the Simplify, I think it's a great disc and it has great imaging, right? And but I'm a little bit leery because we don't have the long-term data that we have for the Pro Disc and the Prestige, for example. You have 30 years of data for the Pro Disc. You have more than 10 years, maybe 15 years by now of the Prestige, and those implants don't seem to wear out. They don't get destroyed by infections like the M6 did, and the Simplify. So far it's a great disc, and I've used it a number of times. But we just don't have 20 years of data. So is that peak material going to hold up to the hardness of the ceramic? I really don't know. I mean, I think it's a great disc, but we don't know everything, and so I've definitely learned to maybe be a little bit more leery, a little bit more cautious, I would say, about new implants.
I love your scientific approach towards this. And it's fun. I mean, Dr. Hodges very well. I mean, this is the stuff that he lives on, is truthfully the biomechanics and being able to understand why things are happening, right? You go back, and even when you talk about your studies previously to inflammation, like what's actually causing the pain? Like what's actually causing the failure? Is it the infection or is it the other way around? As we wrap up here, we've talked about so many different topics. I would feel amiss. We're sitting in this great practice here, but your wife's name is also on the wall. Your wife is an orthopedic surgeon. Yeah. Talk about that story and being able to, one, meet her, back at Stanford, but then just the journey that you guys have had, and now being like, she's also an orthopedic surgeon, specializing in hand and wrist. What that's been like. It's just such a special thing to be able to share.
Yeah, I mean, that's been pretty amazing. It's been a pretty amazing journey. I mean, I met her on the first day of Stanford Medical School. And, we started studying together and got closer, and, I pretty much moved in right away, never moved out. So. And we got married during medical school, and, all along I knew I wanted to be an orthopedic surgeon, and she wasn't really sure what she wanted to do. And maybe I convinced her that, orthopedic surgeon was the best thing to be. I don't know. But, but eventually she decided that's what she wanted to do. And so, we went through that match process together after going through medical school together, which was pretty amazing experience. I mean, I don't have enough good things to say about Stanford. It was amazing, amazing medical school. And then we went to New York, and that was it was a pretty brutal training. I mean, 6 years of East Coast militant style training. But it was an excellent program. But we were in the same program. I mean, luckily, it was a big program. We had 72 residents. So we were able to take vacation together, because if we were in a small program, we wouldn't have been able to do that. So that was great. We get a week at a time. We could take vacation together sometimes, not all the time. We were never allowed to rotate on the same rotation. They were afraid of us working together that closely, I guess. Oh. But we did, get to sit together at our, conferences and, share patients often. And then when we got to LA, we went to different fellowships. So that was another match process, which was another stressor, basically, trying to match in the same city again. And, she wanted to do hand and I wanted to do spine, obviously. So luckily, I matched into Cedars and she matched into USC LA County, which is one of the top fellowships in the country for hand and wrist, or actually the whole upper extremity. And so that was a great year, a tough year of training. And then we entered practice, and we both went into private practice, and we shared an office basically, and which is a great. I mean, it was a good experience. I mean, we worked together well. Luckily, I mean, usually we're not in the office the same day because we're using the same space. So, sometimes we were, and hand and spine actually works quite well together because I mean, she's constantly sending me patients that have numbness in their hand, and she's like, "Well, I think that's from your neck," and I'm sending her patients, a lot of times who, they've got numbness in their small and ring fingers. I'm like, "Well, I think that's actually cubital tunnel syndrome. I think it's carpal tunnel syndrome. So go see my wife." So we do share patients quite a bit. We stopped operating together. We used to assist each other on surgeries, but there's some liability to that, and here in Florida, you don't have malpractice. We don't have malpractice insurance here in Florida. So speaking to the attorneys, they advise us to not do surgery together because I don't want to get into all that, but so we usually don't operate together anymore. But now we have 2 young children, and she actually just started homeschooling, which is pretty amazing. That's a big, huge undertaking. So she's definitely had to cut her work down quite a bit for that. We're very, very blessed that she's able to do that, and she's an amazing teacher. She speaks multiple languages, and our children actually are fluent in French, Spanish, and now they're learning Italian, and so it's pretty amazing.
So more surgeons are going to be in the family probably in the next 20
Who
years.
knows? Who knows? I mean, our son right now, he maybe wants to be a chef. Daughter maybe wants to open up a bookstore, but she's only 5 and he's only 7, so I have no idea. But he recently got really excited by the possibility of becoming a doctor, but not having to ever see blood.
Oh, yeah.
Because he thought that
Surgery.
we actually we're both surgeons, so he doesn't want to see blood. He doesn't want to think about surgery. But then we told him, well, you could be a different type of doctor. He's like, oh my gosh, wow.
Wait a second.
You just opened his world.
Yeah, he was so wide-eyed at that possibility. So we'll see. I don't think we're going to push him, our kids in either direction. But yeah, it's been amazing journey, and I've been very blessed to be with her.
What an incredible thing to share. We don't know if they'll be spine surgeons, but they'll be geniuses.
Yeah, sure.
I was going to say it'd be tough to have someone that is topped your education level, but your wife's hand in hand. I mean, and I thought you were busy, but homeschooling, learning languages, and I mean, that is incredible. But what a special thing to share. And I think it's crazy. You go back to the very start. You guys actually did some research together when you're talking about A2M, alpha-2 macroglobulin. You guys did some of that early preliminary research together. Yeah. Did you not, with Dr. Scuderi?
Yeah, we did.
That's unbelievable. Can you talk a little bit about that too?
Sure.
Because that's we talk about injections, we talk about other therapies, being able to reduce inflammation and essentially harness the power of the body, right? Can you talk about some of that research that you guys did?
Yeah, absolutely. So, I mean, it was quite, life takes you in different ways, right? I mean, so I'd done a PhD before medical school. And so when I got into medical school, I'm like, I'm getting out of here as fast as I can, right? And, but she had a background in molecular biology, and when we were in medical school, she wanted to do an extra year of research. So I was like, okay, I'll stay an extra year for you. So we both went into the lab and did the research year between our second and third year, I guess it was. So we did a full year of extra research at Stanford. It was called Med Scholars Research Program, I think, something like that. And so I wanted to study pain. So I set up my electrophysiology lab where I was recording from spinal cord and brainstem of rats and mice, like I did at UC Davis. And we also wanted to study inflammation. And I had this idea of a project. Okay, I want to try to lavage the epidural space in patients that have a disc herniation and try to see if there are any inflammatory cytokines in that space that are in contact with the nerve and the disc herniation that are possibly causing that sciatic pain. So talked to my anesthesia mentor at Stanford, and he was like, oh, I don't know if we can do that. well, we can try it. So, he tried one time and, couldn't get any fluid out. And he's like, okay, well, I guess it's not possible. And then I was talking to my other colleague, mentor, Dr. Pasquale Montesano, about it. And he's like, oh, you should talk to my buddy out in Jupiter, Florida. He did a study kind of like that. And so gave me his number. And, so I was a second year medical student, I think, at this point, and Dr. Scuderi had been a spine surgeon for maybe 10 years. And so I called him and told him my idea. And he's like, oh, I already did it. And he's like, and the study was negative. I didn't get anything. I didn't find anything. And I was like, really? Well, how'd you do it? And, so we talked about the, scientific project and exactly how he did it. And so brainstormed with him and my mentors at Stanford and realized that, we had to process the samples a little bit different. So he was actually, Dr. Scuderi was successful in rinsing out the epidural space and getting fluid back. My anesthesia colleagues at Stanford weren't able to do that. But he had done the whole study. He had looked for cytokines in that fluid and found nothing at all. But basically, they weren't protecting the samples from proteases. So we redid the study with protease inhibitors, and we found a protein that we thought was interferon gamma. And then this turns into a whole long story, but it's fascinating. So I mean, it becomes very complicated. So we spent like a couple of years trying to figure out like what this protein signal was that was coming through as interferon gamma. And I mean, Dr. Scuderi started this company called Cytonics, hired scientists, protein specialists, Lewis Hanna, who tried to verify and figure out, what the signal was. And it turned out it was something called fibronectin aggrecan. It was fibronectin aggrecan complex. So it was these molecular breakdown products that were present in inflammation and cartilage degradation with different kinds of arthritis. Then we started working on, okay, well, we have this inflammatory marker, this biomarker. We don't know, is it causing the pain or it's just there, but maybe we can block it somehow. So then we started looking at older literature, and we found this protein alpha-2 macroglobulin, which has never been described to be used for any sort of treatment, but it was there. It was this master protease inhibitor. So we had to design a rabbit study. We went to Montreal and did this rabbit ACL transection study, which is crazy. But actually injecting A2M into the rabbit knee at the time that you transect it prevents them from getting osteoarthritis of the knee. Whereas the rabbits that got saline, they developed pretty severe osteoarthritis. So it was able to prevent osteoarthritis development in these rabbits. So we started using it in humans for all sorts of arthritis, and it works amazingly well for knee arthritis. I mean, I've injected in so many people. For example, I had my surgery scheduler in Beverly Hills. Her mom had like bone-on-bone knee arthritis with a deformity, and she had been told she needed a knee replacement. She's like, I don't want a knee replacement. So I was like, well, let's give it a try. I injected her. She's 5 years. She had no pain.
No way.
That's amazing. I mean, that's unusually long. Usually, on average, it's like a year. But a pretty significant pain relief. I mean, I've done a lot of people. It seems to work the best for the knees, but I've done a lot of hips. It works great for the hips. It works for the shoulder if you can get it in the right spot. I've done ankles. I haven't had as good of luck with ankles, but I've only done a couple, and they've been like unstable ankles. So we'll see if I get a normal arthritis ankle if it works. But quite a few shoulders, hips, and knees has been very successful. So the next level, this is going to blow your mind. Okay, so after using autologous A2M for multiple years, where we take blood out. So we thought, well, it'd be great to be able to just pull it off the shelf from a bottle, right? So and you can't patent a natural protein, right? So, and this is way above my educational level. So we had geneticists and protein biochemists basically tweak the genetic code for A2M and make the bait region a little bit better. And then now we're able to mass produce this recombinant. So we call it recombinant A2M. Of course, we had to test multiple different versions of it. So Cytonics was able to tweak and patent a new version of recombinant A2M that's now about to enter phase 2 human clinical trials in Australia. So we've gotten through safety studies with flying colors, and now it's going into the first patient for phase 2 pretty soon. So I think that's going to be absolutely game changing for arthritis treatment.
It's amazing the time and just energy and the dedication that goes in to get something to where it is, right? We're well versed in the clinical trial process as well, and just like something doesn't show up and then is on the market tomorrow, right? It's people don't see the 5 years and the 10 years and the 15 years of everything that works, but then these like little pivot points, right? Like figuring out what works and what doesn't.
You had to go down so many paths to get to the one you're at, which is probably not where you thought you would be at all. It's not where you started, and it's like you end up a rabbit hole after rabbit hole that ends up in this amazing place because you're willing to just keep going.
And I mean, I have to give it all to Dr. Gaetano Scuderi. I mean, he's just grinded it out for 20 years. I mean, and of his own personal money, his time, and just not giving up. I mean, I've been involved at several stages, but he's just been involved from the beginning and been the real driver for it. And it's amazing to have that dedication and persistence. And many times throughout every year, he's telling me, I'm sick of this. I gotta get out of there. But he keeps going. He keeps going. It's like he's seen it to the end. So it'll be amazing to see it come to the end and actually be in actual treatment phase.
As we talk about all this, I hear you talk about, we've talked about your patients and truthfully just your dedication to helping others and your craft and your relationship and your family. I've gotten to know you as a surgeon. I've also gotten to know you as a man of faith. And can you talk a little bit about that? I've been fortunate enough to know you on that and know your grounding and your basis, what that's contributed and how that's guided you throughout your life, both in your, professional career and working with patients and in your relationship with your wife and your kids and just what that means to you.
Yeah. I mean, that's certainly been a journey as well. And, throughout my life, I mean, my parents were, Christian, but we weren't, super Christian. Like, I guess you would say. I mean, we went to church once in a while, and it wasn't like a huge part of our life. And my grandmother was Catholic, and she wasn't really pushy on it, right? I mean, she wanted us to be Catholic, and but I never really turned to religion that much until much later in my life, and I think especially when I had kids, I think kind of realization hit me that it's really important to have something greater than us, and I think that's kind of led my faith journey, more recently, and so I've gotten involved in a men's group here in Florida, which is just been amazing, and I think that's been a big difference also from California and Florida, and not to bring up politics and everything, but definitely, I mean, I've been surrounded by a Christian brotherhood here that's been amazing. I think that being able to get that guidance, from them, and really kind of looking to into God and to Christ for guidance in everything I do, has really been life changing for me. I think it's been very beneficial, and every surgery that I do, I definitely ask God to guide my hands, guide my decisions, and help give me that perfect outcome, because I can't do it alone.
Absolutely. I think, and being the point that you brought up, I think resonates so strongly is being able to find that community too, right? Where you can share that and grow deeper in it, whether it's your relationship, your profession, your profession and what you do. You resonate with so many different things, and we appreciate it. We appreciate all the time that you've given us today. The one thing I really want to wrap on is I saw a post on, you're not just a surgeon, you're also a builder of playhouses for your children. And this is no playhouse. This has got a roof and shingles.
Is it better than our own houses?
Oh my goodness. But I got to get an update. What does it look like now? Because I was jealous watching that. That is like a kid's dream to see that. But instead of having a burr in your hand, you've got a DeWalt drill in your hand. So it's pretty amazing to see.
So I stopped posting progress because my wife actually doesn't like me to post any personal stuff. So I stopped. But it actually is pretty much finished now. I'm doing the last few coats of paint on the wraparound porch that I just built on it. So it's it's gotten a little bit out of control. But my son asked for this and that. He's like, I want I want a trap door in
Me
the
too.
floor. In the floor. And I'm like, well, it's Florida. If I dig down, I think we're gonna hit water. So I got so I built this toy box in the back, and then it has an escape door in the back that opens up. So he can go into the box, close the door, and disappear. And his friends are like, where'd he go? So he loves that.
So fun.
And then there's an upstairs loft, and it was. Honestly, it was just a lot of fun to do, and my wife kept saying, "Oh, why don't you just order something, online or whatever?" In the beginning, and then she saw, that I was having fun with it and really learning a lot, and it really gave me a lot of I want to say gratitude, but a lot of respect for a lot of different workers. For example, when I was doing the roof, and I had no idea how to do a roof. I mean, I learned a lot of things from my father about building things, but we had not done our own roofs, and so I had to go to YouTube, and I was watching professional roofers. Luckily, there's a lot of actually great videos on how to make a roof on YouTube, right? So I was watching this guy. I mean, I had to calculate the pitch of the roof, and then build the trusses, and then put on the plywood, and then the actual getting up on the roof and doing the actual shingles and all the layers. I didn't realize there's so many layers, right? I had to get, and so climbing the ladder with like 60 pounds of shingles on my shoulder, and then standing at an angle doing the nail gun. I was like, man, these roofers, they work really hard. This is a really tough job. And then I tiled the floor, which you may think is crazy for a playhouse, but
yeah,
it's so humid.
Which I think is crazy,
but it's so humid in Florida. So I originally bought this very cheap like vinyl floor, and then just sitting out in the driveway for a week, it like molded immediately. I was like, oh, okay, I have to do something more waterproof for Florida. So I did a porcelain tile floor that looks like wood. And as I'm on my hands and knees doing the grout, I'm like, this is another job that I really appreciate other people doing.
And gratitude for your disc replacement, I'm sure.
Yeah, exactly.
I know. What a cool experience to be able to share too, and share with your kids and your family. I think next time we're in town, we're gonna have to come check it out.
Yeah, can we stay there?
Yeah. If you want. There's no air conditioning, so if it's in the winter months, you'll be fine. But in the summer, you might be a bit hot.
That's amazing. Well, we can't say enough good things about you. This has been incredible. I think just for patients to be able to hear this perspective as well, and the depth of knowledge that you have and the perspective that you have, not just being a surgeon, but being on the patient side as well. Mm-hmm. For patients that haven't seen it, you have 3,000 followers on Instagram. You put a lot of patient education out there. People absolutely should go consume your content because it's great to see. And when you're trying to get different perspectives and learn, where else can people find you? We want to wrap up. We want to make sure that people can find you that are looking for you. Where can people go to find you?
Cuéllarspine.com. It's my website. As you mentioned, Instagram at Cuéllarspine, I think it is. And I do have a YouTube channel. Not many followers, but that's so those are the main places. Yeah.
But there's great patient videos on there as well. There's patient testimonials. There's patient education, and I think that's what we try and promote is people have access to what they're looking for, right? So, we are gracious. We have a lot of gratitude that we were able to make this happen. We have so much respect for you and everything you've done for the spine community. Thank you for giving us so much time today, and we appreciate it for all of our listeners as well. So thank you so much, Dr. Cuéllar.
You're very welcome. Honored to be on this excellent podcast, and thank you so much for having me.
Absolutely. We'll see you soon.